Well, thank you very much for giving me the opportunity to present my work today on characterizing potential medication-related harm in the 30 days following hospitalization using linked provincial administrative health data from the province of Ontario in Canada. I'd like to thank the co-authors for the contributions. We're from the Institute for Better Health at Trillium Health Partners, as well as the Institute of Health Policy Management and Evaluation at the University of Toronto. To get started with a little bit of background, many patients experience preventable adverse events in the transition between hospital and home. Adverse drug events, or ADEs, impact about 50% of patients in the 30 days post-discharge. So ADEs include any harm caused by a medication. So this can include adverse drug reactions and overdoses, as well as harm from the inappropriate use or prescribing of a particular medication. An approach that can or may decrease the incidence of adverse drug events in the transition between hospital and home centers around pharmacist-led interventions in hospital. However, in order to better target these particular interventions, we require a better understanding of which patients and which medications to target. So the objectives of this study were to describe patterns of medication prescribing for patients discharged from hospital to home, and to understand which patients are at highest risk of experiencing an adverse drug event following discharge related to their medications. In terms of our study design and setting, this was a retrospective cohort study of Ontario residents in the province of Canada. We conducted this study using multiple linked population health data sets. Ontario is a diverse multicultural population and it has approximately 14 million people living in the province. All residents who are all years of age receive universal access to physician and hospital services, and the province of Ontario provides public drug insurance to all those who are 65 years of age and older, as well as those who are low income and those with certain conditions and disabilities. In terms of the data sources that were used in this study, patient demographics and healthcare records were linked using a patient's encrypted healthcare number. The Ontario Drug Benefit Database was evaluated, and it contains all medication claims for all those in the province with public drug coverage. We also used the Discharge Abstract Database, as well as the National Ambulatory Care Reporting System, which contains information on all admissions to hospital, as well as all emergency department visits. Our study population included all patients discharged home from the community from an Ontario hospital in 2016-2017, with medications dispensed in the 30 days following hospital discharge. With respect to using administrative health data to capture potential adverse drug events, unfortunately, the occurrence of adverse drug events are not routinely measured or recorded for hospitalized patients, since clinical adjudication is very resource intensive. ICD codes only have a sensitivity of about 28% to capture ADEs as well. So given these challenges, we decided to use all-cause ED visits and mortality in 30 days post-discharge to capture potential medication-related harm. In terms of our statistical analysis, we use logistic regression to determine the association between medications at discharge and ED visits and mortality in 30 days post-discharge. And to account for confounding by patient severity, we adjusted for the LACE index, as well as main patient service, discharge disposition, and the number of medications that were dispensed. So moving along to our results, our study population included about 248,000 patients discharged from hospital with medications dispensed in the 30 days following discharge. And that resulted in approximately 1.6 million medication dispensations that were analyzed. For our baseline characteristics, in terms of patient demographics, median age was 74, and about 54% of individuals were females. Most patients didn't have any pre-admission hospitalizations in the year prior to their index admission, with 79% of patients not having any. The median number of ED visits in the year prior to index admission was 2, and patients had a median of 9 medications dispensed in the 30 days following discharge, and 13% of individuals had 16 or more medications dispensed. When we looked at characteristics of the index hospitalization, we found that the median length of stay was about 4 days. The number of chronic conditions individuals had measured using the Charleston Comorbidity Index, 42% didn't have any Charleston comorbidities, and about 36% of individuals had one, 6% had 3 or more. When we looked at where patients were discharged to, leaving hospital, long-term care, continuing care accounted for 12% of discharges, 37% of patients were discharged home with support services, and 51% of patients were discharged home with no support services. The majority of patients in our study were general medicine patients, orthopedic surgery, and general surgery patients. When we looked at medications dispensed in the 30 days following discharge, we found that when we looked at the distribution of the number of medications dispensed overall, 21% of patients had one medication dispensed, while 20% had 2 and 14% had 3. When we looked at the number of new medications that were dispensed to patients, we found that about 21% didn't have any new medications dispensed, about 33% had 1, and 23% had 2 new medications dispensed. When we looked at the 20 most common ingredients dispensed to patients in the 30 days post-discharge, we found the most common medications included hydromorphone, pantoprazole, furosemide, and atorvastatin, with 17% of patients being dispensed hydromorphone in the 30 days following discharge, and 16% were dispensed pantoprazole. When we looked at the proportion of those medications that were considered new, we found that 70% of all hydromorphone prescriptions were new to the patient in the 30 days post-discharge, and 38% of pantoprazole prescriptions were new, and 32% of furosemide prescriptions were new. Surprisingly, an anticoagulant, rivaroxaban, was demonstrated that about 80% of those prescriptions were new, and 70% of oxycodone prescriptions were new. When we looked at higher harm medications that were dispensed 30 days post-discharge, we found that overall, 34% of patients were dispensed an opioid, 23% were dispensed an antibiotic, 17% were dispensed antidepressants, and 28% received an anticoagulant. When we looked at the proportion of those high harm medications that were new, 69% of all opioids dispensed were new to that particular patient, 80% of antibiotics were new, and 85% of benzodiazepines were new. When we looked at predicting potential medication-related harm in the 30 days following discharge, we found that approximately 27% of patients experienced an emergency department visit in the 30 days post-discharge, and 2% of individuals died. When we looked at the association between patient and medication level variables and adverse events in the 30 days post-discharge using our BASE model, so this was a model that included the LACE variables that were part of the LACE Plus index, as well as adjusting for main patient service and discharge disposition, we found that there were a number of variables that were associated with an increased risk of emergency department visits and mortality in the 30 days post-discharge. Of interest, patients who were admitted from the emergency department were at a 17% higher risk of an ED visit or mortality in 30 days. Patients who were discharged from a medical unit were at 26% increased risk, and patients discharged from an oncology unit had 2 times the risk of ED visits or mortality in 30 days. And patients who were discharged home with support services or home with no support services were also at an increased risk of ED visits and mortality in 30 days compared to patients who were discharged to long-term care or continuing care. So then when we adjusted for all these variables that were in our BASE model, plus the number of new medications, or number of medications overall, we found that the total number of medications dispensed in the year prior to admission, each additional medication was associated with a 2% increased risk of adverse events in 30 days, and the total number of new medications dispensed post-discharge was associated with a 3% increased risk. When we looked at models that included adjustments for our BASE model, the number of dispensed medications and the the receipt of high harm medications, we found that patients who received an opioid, antihypertensive, corticosteroid, or antibiotic in the 30 days following discharge were at an increased risk of adverse events. And this association was even higher among patients who were receiving new versions of these medications. So a patient who received a new opioid in the 30 days post-discharge had a 13% higher risk of ED visits and mortality in 30 days. And patients who received new antihypertensives had a 33% increased risk of these adverse events in 30 days. So overall, we found that use of new high-risk medication classes in the 30 days following discharge was common, and that this was a potential risk factor for adverse drug events. So we think that patients prescribed these medications would likely benefit from additional education and monitoring by the hospital pharmacy team, and that overall, entire hospitals may benefit from greater pharmacy support services. Thank you very much for your attention and for listening today.